A kidney transplant is a surgery done to replace a diseased kidney with a healthy kidney from a donor. The kidney may come from a deceased organ donor or from a living donor. Family members or others who are a good match may be able to donate one of their kidneys. This type of transplant is called a living transplant. People who donate a kidney can live healthy lives with one healthy kidney. A person getting a transplant most often gets just one kidney. In rare situations, he or she may get two kidneys from a deceased donor. The diseased kidneys are usually left in place. The transplanted kidney is placed in the lower belly on the front side of the body. You may need a kidney transplant if you have end-stage renal disease (SRD). This is a permanent condition of kidney failure. It often needs dialysis. This is a process used to remove wastes and other substances from the blood. The kidneys remove urea and liquid waste from the blood in the form of urine. Urea is made when foods containing protein, such as meat, poultry, and certain vegetables, are broken down in the body. Urea is carried in the blood to the kidneys. Balanced salts, electrolytes such as potassium and sodium, and other substances in the blood. Produce erythropoietin, a hormone that aids the formation of red blood cells. Regulate blood pressure. Regulate fluid and acid-base balance in the body to keep it neutral. This is needed for normal function of many processes within the body. Some conditions of the kidneys that may result in SRD include repeated urinary infections, kidney failure caused by diabetes or high blood pressure, polycystic kidney disease or other inherited disorders, Lemmer-Lennertz, which is inflammation of the kidney's filtering unit, hemolytic uremic syndrome, a rare disorder that causes kidney failure, lupus and other diseases of the immune system, obstructions, other conditions, such as congenital defects of the kidneys, may result in the need for a kidney transplant. There may be other reasons for your healthcare provider to recommend a kidney transplant. What are the risks for kidney transplant? As with any surgery, complications can occur. Some complications may include bleeding, infection, blockage of the blood vessels to the new kidney, leakage of urine or blockage of urine in the ureter, lack of function of the new kidney at first. The new kidney may be rejected. Rejection is a normal reaction of the body to a foreign object or tissue. When a new kidney is transplanted into a recipient's body, the immune system reacts to what it thinks is a threat and attacks the new organ. For a transplanted organ to survive, medicines must be taken to trick the immune system into accepting the transplant and not attacking it as a foreign object. The medicines used to prevent or treat rejection have side effects. The exact side effects will depend on the specific medicines that are taken. Not everyone is a candidate for kidney transplantation. You may not be eligible if you have current or recurring infection that cannot be treated effectively, cancer that has spread from its original location to elsewhere in the body, severe heart or other health problems that make it unsafe to have surgery, serious conditions other than kidney disease that would not get better after transplantation, failing to follow the treatment plan. There may be other risks depending on your specific medical condition. Be sure to discuss any concerns with your transplant team before the procedure. More information about organ donation from Johns Hopkins Medicine. Map of kidney recipients. Could you give a kidney to a To get a kidney from an organ donor who has died a cadaver, it must be placed on a waiting list of the United Network for Organ Sharing (UNOSA). Extensive testing must be done before you can be placed on the transplant list. A transplant team carries out the evaluation process for a kidney. The team includes a transplant surgeon, a transplant nephrologist, a healthcare provider specializing in the treatment of the kidneys, one or more transplant nurses, a social worker, and a psychiatrist or psychologist. Other team members may include a dietitian, a chaplain, and/or an anesthesiologist. The evaluation includes mental health evaluation, psychological and social issues involved in organ transplantation, such as stress, financial issues, and support by family and/or significant others are assessed. These issues can greatly affect the outcome of a transplant. The same kind of evaluation is done for a living donor. Blood tests. Blood tests are done to help find a good donor match, to check your priority on the donor list, and to help the chances that the donor organ will not be rejected. Diagnostic tests. Diagnostic tests may be done to check your kidneys as well as your overall health status. These tests may include X-rays, ultrasound, kidney biopsy, and dental exams. Women may get a pap test, gynecology evaluation, and a mammogram. The transplant team will weigh all the facts from interviews, your medical history, physical exam, and tests to determine your eligibility for kidney transplantation. Once you have been accepted as a transplant candidate, you will be placed on the UNO's list. When a donor organ becomes available, you will be notified and told to come to the hospital right away. If you are to get a kidney from a living family member, a living or related transplanter, the transplant may be done at a planned time. The donor must have a compatible blood type and be in good health. A mental health check will be done to be sure the donor is comfortable with the decision. These steps will happen before the transplant. Your transplant team will explain the procedure to you and you can ask questions. You will be asked to sign a consent form that gives your permission to do the surgery. Read the form carefully and ask questions if something is not clear. If you have been on routine dialysis before the procedure, you will get dialysis before the procedure. For a planned living transplant, you should fast for 8 hours before the operation, generally after midnight. In the case of a cadaver organ transplant, you should start to fast once you are told a kidney has become available. You may get a sedative before the procedure to help you relax. Based on your medical condition, your transplant team may ask for other specific preparation. A kidney transplant requires a stay in a hospital. Procedures may vary depending on your condition and your healthcare provider's practices. Generally, a kidney transplant follows this process. You will remove your clothing and put on a hospital gown. An intravenous fluid line will be started in your arm or hand. More catheters may be put in your neck and wrist to monitor the status of your heart and blood pressure, and to take blood samples. Other sites for catheters include under the collarbone area and the groin blood vessels. If there is too much hair at the surgical site, it may be shaved off. A urinary catheter will be inserted into your bladder. You will be positioned on the operating table, lying on your back. Kidney transplant surgery will be done while you are asleep under general anesthesia. A tube will be inserted through your mouth into your lungs. The tube will be attached to a ventilator that will breathe for you during the procedure. The anesthesiologist will closely watch your heart rate, blood pressure, breathing, and blood oxygen level during the surgery. The skin over the surgical site will be cleansed with an antiseptic solution. The healthcare provider will make a long incision into the lower abdomen on one side. The healthcare provider will visually inspect the donor kidney before implanting it. The donor kidney will be placed into the belly. A left donor kidney will be implanted on your right side, or right donor kidney will be implanted on your left side. This allows the ureter to be accessed easily for connection to your bladder. The renal artery and vein of the donor kidney will be sewn to the external iliac artery and vein. After the artery and vein are attached, the blood flow through these vessels will be checked for bleeding at the suture lines. The donor ureter, the tube that drains urine from the kidney, will be connected to your bladder. The incision will be closed with stitches or surgical staples. A drain may be placed in the incision site to reduce swelling. A sterile bandage or dressing will be applied. Talk with your healthcare provider about what you will go through during your kidney transplant. In the hospital, after the surgery, you will be taken to the recovery room. A kidney from a living donor may start to make urine right away. Urine production in a cadaver kidney may take longer. You may need to continue dialysis until urine output is normal. You will have a catheter in your bladder to drain your urine. The amount of urine will be measured to check how the new kidney is working. You will get fluids until you are able to eat and drink enough on your own. Your team will closely watch how your anti-rejection medicines are working to make sure you are getting the best dose and the best combination of medicines. Blood samples will be taken often to check the status of the new kidney, as well as other body functions such as the liver, lungs, and blood system. You will slowly move from liquids to more solid foods as tolerated. Your fluids may be limited until the new kidney is working fully. Usually, by the day after the procedure, you may start moving around. You should get out of bed and move around several times a day. Take a pain reliever for soreness as advised by your healthcare provider. Avoid aspirin or certain other pain medicines that may increase the chance of bleeding. Be sure to take only recommended medicines. Nurses, pharmacists, dietitians, physical therapists, and other members of the transplant team will teach you how to take care of yourself once you are discharged from the hospital, including care for your incisions. You will be ready to go home when your vital signs are stable, the new kidney is working, and you do not need the constant hospital care. Once you are home, it is important to keep the surgical area clean and dry. Your healthcare provider will give you specific bathing instructions. Generally, the incision should not be submerged in water until the skin heals, as this increases the risk for infection. The stitches or surgical staples will be removed during a follow-up office visit. You should not drive until your healthcare provider tells you it's okay. Plan to have someone drive you home from the hospital and to your followed-up appointments. Avoid any activity or position that causes pressure to be placed on the new kidney. Other activity restrictions may apply. Check your blood pressure and weight at home every day. Increases in these may mean your kidneys are not filtering fluid properly. You need to be seen by your transplant team promptly. Tell your healthcare provider if you have fever, which may be a sign of rejection or infection, redness, swelling, or bleeding or other drainage from the incision site. Increase in pain around the incision site, which may be a sign of rejection or infection. Fever and tenderness over the kidney are some of the most common symptoms of rejection. A rise in your blood creatinine level, a blood test to measure kidney function, and/or blood pressure may also suggest rejection. The symptoms of rejection may look like other medical conditions or problems. Talk with your transplant team with any concerns you have. Frequent visits to contact with the transplant team are vital. Avoid places in which you may be exposed to anyone who may be sick. This is because your immune system will be suppressed to protect you from rejecting the new kidney. This will be a lifelong precaution. Your healthcare team may give you other instructions after the procedure, depending on your situation. What is done to prevent rejection? To allow the transplanted kidney to survive in your body, you will be given medicines for the rest of your life to fight rejection. Each person may react differently to medicines. New anti-rejection medicines are continually being developed and approved. Your healthcare team will tailor medicine regimes to meet your needs. Usually, several anti-rejection medicines are given at first. The doses of these medicines may change often, depending on your response. Because anti-rejection medicines affect the immune system, you will be at higher risk for infections. A balance must be maintained between preventing rejection and making you very susceptible to infection. Some of the infections you will be especially at risk for include oral yeast infection, thrush, herpes, and respiratory viruses. Avoid contact with crowds and anyone who has an infection for the first few months after your surgery. What to expect the day of surgery. On the day of surgery, you will meet with the medical team involved in your surgery. This will include your surgeon, the anesthesiologist, an operating room nurse, and various other healthcare professionals. Getting ready for surgery. You may expect some of the following to happen. You may need to change into a hospital gown. You will receive an bracelet. An intravenous catheter with it may be inserted in your forearm or other location for anesthetics and other medicines. You may be transported on a stretcher to the operating room. What does the operating room look like? The operating room can be an intimidating, busy place. It has a lot of unfamiliar technical equipment. The following is a brief list of equipment you may see in the operating room. Each operating room varies depending on the type of surgery being done. The operating table in the center of the room can be raised, lowered, and tilted in any direction. The operating room lamps allow for brilliant illumination without shadows during surgery. You will be connected to various monitors that keep track of your vital signs. These include your heart rate and blood pressure. A ventilator or breathing machine stands by the head of the operating table. If your procedure is done under general anesthesia, a ventilator will breathe for you during the procedure by moving oxygen and air in and out of your lungs. Sterile instruments to be used during surgery are arranged on a stainless steel table. A diathermy machine to control bleeding usually is present. If the surgery needs it, a hard lung machine or other specialized equipment may be brought into the room. The operating room will likely be cold to minimize bacterial growth. Pancreas transplantation is a type of surgery in which you receive a healthy donor pancreas. A pancreas transplant is a choice for some people with type 1 diabetes. Type 1 diabetes is an autoimmune disease in which the pancreas stops producing the hormone insulin. The usual treatment for type 1 diabetes involves daily injections of insulin. During a pancreas transplant, you will receive a healthy pancreas from a donor who has died. If you have kidney failure from your diabetes, your surgeon may also do kidney transplant at the same time. The kidney transplant may be done earlier or even after the pancreas transplant. In a pancreas transplant, your own pancreas remains in your body. The surgeon generally connects the new pancreas to your intestines so its digestive juices can drain. After a successful transplant, you will no longer need to take insulin. Instead, the new pancreas will create insulin for you. You can eat a regular diet too. You will have fewer no episodes of low or very high blood sugar or insulin shock, and your risk for kidney damage will go down. Who is a candidate for the transplant? Candidates for pancreas transplantation generally have type 1 diabetes, usually along with kidney damage, nerve damage, problems, or another complication of the disease. Usually, healthcare providers consider a transplant for someone whose diabetes is out of control even with medical treatment. This is true especially when low blood sugar hypoglycemia has been a long-lasting problem. What are the risks? The procedure's risks are infection and organ rejection. Rejection happens when the body's immune system attacks the new organ as a foreign invader. To reduce the chances of rejection, the healthcare team tries to match the blood and tissue type of the organ donor to the person getting the transplant. After the transplant, healthcare providers prescribe special medicines that suppress the immune system, such as azotapoin and cyclosporine, to help prevent rejection of the new pancreas. However, these medicines make it more likely for people with a transplanted organ to pick up infections like colds and the flu. Over time, the medicines may also increase the risk for certain cancers. Because of the higher risk for skin cancer, for example, it's important to cover up and wear sunscreen. If you get a pancreas transplant, you must take special medicines as long as you have the transplanted organ in your body. You will also need. Is there a waiting list? Currently, more people are in need of a healthy pancreas than can be provided for with donors. The wait for a pancreas can be quite long on average, about 3 years. Surgeons may plan to do a pancreas transplant at the same time as a kidney transplant to help control blood glucose levels and reduce damage to the new kidney. The chance of rejection is less if the immune characteristics of the donated organ match more and are capable of existing with those of the patient who receives the transplant. What is the outlook after a pancreas transplant? The long-term outlook for people who receive a pancreas transplant is quite good. People who receive simultaneous kidney-pancreas transplants also tend to have less chance of rejection. A positive long-term result depends on a number of factors including control of blood glucose. What is surgical pathology? Surgical pathology is the study of tissues removed from living patients during surgery to help diagnose a disease and determine a treatment plan. Often, the surgical pathologist provides consultation services in a wide variety of organ systems and medical subspecialties. Surgical pathologists provide diagnostic information and/or second opinions. For example, when performing breast cancer surgery, a surgical pathologist's exam of tissues removed during surgery can help the surgeon to determine whether to remove lymph nodes under the arm as well. Surgical pathology includes both the physical exam of the tissue with the naked eye as well as examining processed tissue under a microscope. New techniques of exam of tissue and cell specimens involve molecular diagnostics and DNA-RNA analysis. This involves analyzing DNA and proteins in the blood. Examples of the uses of the technology include the ability to distinguish between benign and non-cancerous and malignant or cancerous white blood cells, detect early genetic changes that may result in cancer, identify infectious agents in body tissues. There are two major types of specimens submitted for surgical pathology analysis of biopsies and surgical resections. 1. A biopsy is a small piece of tissue removed primarily for the purposes of surgical pathology analysis, most often in order to render a definitive diagnosis. Types of biopsies include core biopsies, which are obtained through the use of large bore needles, sometimes under the guidance of radiological techniques such as ultrasound, cord scan, or magnetic resonance imaging. Core biopsies, which preserve tissue architecture, should not be confused with fine needle aspiration specimens, which are analyzed using cytopathohaley techniques. Incisional biopsies are obtained through diagnostic surgical procedures that remove part of a surgical resection. Specimens are obtained by the therapeutic surgical removal of an entire diseased area or organ, and occasionally multiple organs. These procedures are often intended as definitive surgical treatment of a disease in which the diagnosis is already known or strongly suspected. However, pathological analysis of these specimens is critically important in confirming the previous diagnosis, staging the extent of malignant disease, establishing whether or not the entire diseased area was removed, a process called determination of the surgical margin, often using frozen section, identifying the presence of unsuspected. In the determination of surgical margin of a surgical resection, one can use the bread loafing technique, or CATPA. A special type of CATPA is named after a general surgeon, or the Moss surgery method. Many pathologists seek fellowship-level training, or otherwise pursue expertise in a focused area of surgical pathology. Subspecialization is particularly prevalent in the academic setting, where pathologists may specialize in an area of diagnostic surgical pathology that is relevant to their research, but is becoming increasingly prevalent in private practice as well. Subspecialization has a number of benefits, such as allowing for increased experience and skill at interpreting challenging cases, as well as development of a closer working relationship between the pathologist and clinicians within the subspecialty area. Commonly recognized bone pathology, cardiac pathology, cytopathohaley abortocervical subspecialty in the U.S., dermatopathology abortocervical subspecialty in the U.S., endocrine pathology, gastrointestinal pathology, genitourinary pathology, gynecologic pathology, head and neck pathology, hematopathology abortocervical subspecialty in the U.S., neurophilology abortocervical subspecialty in the U.S., and a recognized specialty in the UK. Ophthalmic pathology, pediatric pathology abortocervical subspecialty in the US, and a recognized specialty in the UK. Pulmonary pathology, renal pathology, soft tissue pathology, breast pathology,